In this episode, you will learn if you or someone you're with gets a snake bite, step back, sit down, assess the situation, and get help as soon as possible. In the ED, snake bites should be treated as medical emergencies, and patients should be prioritized for rapid assessment and management. Time is tissue. If the patient has significant swelling, bleeding, or lab abnormalities, treat with antivenom. Call your toxicologist or poison control to help guide treatment. These patients should be admitted to the ICU for frequent monitoring of limb circumference and lab abnormalities. If swelling is worsening, give more antivenom. Surgical management is almost never the answer.
Welcome to EM Pulse, bringing research and expert opinion to the bedside.
We're your hosts, Sarah Medeiros
and Julia Magana. Welcome back to EM Pulse. We're recording this at the end of the summer. And in our house, that always means that we're out hiking and by the water in California. And that also means inevitably there are warning signs for rattlesnakes. It also means that I am likely to care for a child who was running through the yard and said, "Mommy, look at this pretty snake I found." To help me take care of my own family and our patients better, I am here with Dr. Jonathan Ford, professor of emergency medicine and medical toxicologist. Okay, let's start outside of the hospital. You're hiking and a fellow hiker is bit by a snake. What is the latest on what we do? Are we like sucking the venom out of the wound with our mouth, or have we moved past that?
Thankfully, we've moved past that. First, don't make it worse, right? So if you're bit by a snake, you want to take a few steps back to a safe place where you could sit down, gather your thoughts, make sure you're feeling okay. Some patients will feel lightheaded. They may even pass out. So you want to make sure that you're going to pass out in a safe area. And then once you've got your thoughts together, you want to try to just get out as fast as you can. If you've got cell phone signal, great, call 911. Try to relay the location where you're at to the rangers and EMS personnel. If you're not in a cell phone coverage area, you want to just find the quickest way out to civilization to where you can call for help. As far as the bite site, you don't need to do anything to it. Those of us who treat snakebite victims all have stories about what people do to the snakebite areas, including electrocution, cutting, sucking, pinching. Don't do any of that. It's just going to make it worse.
Oh my goodness. Electrocution.
Electrocution, yeah. My mentor gave a great story of how two buddies were out with the snake and they took some jumper cables from their car and hooked it up to the battery and then electrocuted the bite site, and the guy ended up losing a limb from the electrocution. So it's just not necessary to do that.
It's way worse.
It makes it way worse. Yeah, no tourniquets, no cutting. And, with these bite sites, they're relatively clean. They're not dirty dog, human mouth. And as soon as you put your human mouth on it, now you've made a very dirty wound out of it. There are some lab studies that actually show that the venom is bactericidal. So it's relatively clean. So don't make it worse.
Okay. Don't make it worse. Get back to safety. Don't electrocute yourself.
Exactly.
Heard. And also, it sounds like don't invest in one of those snake bite kits that you can carry in your backpack or something like that.
Exactly. Those have not been proven to be very effective at all.
Okay, what about people bringing in the snakes, Jonathan? You and I, we've all had somebody come in with a bag with a snake. Fortunately, there are cell phones out there, but let's just say it. Should we be bringing in the snake?
Absolutely not. No, there is no need to bring the snake in. A picture's great, but even if you don't have a picture, or even if you're not sure what the snake was, we can still take care of you, even without identifying the snake. There are plenty of stories of decapitated snakeheads being brought in. Those are still able to bite and inject venom into you several minutes afterwards because of just a spinal reflex. There's a publication of a provider being bit by a snake that was brought into the emergency department. Just don't do it. It's not worth the time. It's not worth the risk. We can treat the patient without knowing for sure what kind of snake it was.
And then what are we asking the pre-hospital people to do when they respond to a hiker that has been bitten? What should they do in the pre-hospital field?
So it's going to be general pre-hospital management. We want to make sure to assess the airway. There's going to be a very small set of patients who are going to have anaphylaxis or anaphylactoid reactions. So definitely want to assess the airway, make sure they're breathing okay, that there's no angioedema. Some people are going to become hypotensive, maybe pass out. So we want to make sure that we establish an IV, get them some fluids. And the IV we want to establish is going to be in the unaffected limb. And if it's in lower extremities, it doesn't matter. But if it's in an upper extremity, establish an IV in the opposite limb, give them some fluids, and then we want to just transport to the nearest hospital.
That was going to be my next question. Like, do we go to the hospital that has all the resources, or do we just go to the closest access hospital, assuming you're out in the middle of nowhere?
Yeah, so you want to go to the nearest hospital, and that's because time is tissue. The venom acts very quickly. You're going to start having tissue damage. They're cytotoxic. They're also hemotoxic, so some patients may start bleeding very quickly. So we want to go to the nearest emergency department because most, if not all, emergency departments are going to at least have the initial dose of antivenom.
What if it's a kid, Jonathan? Anything that we're going to change based off of the age?
So I'd still recommend that you go to the nearest hospital. And that's because, again, time is tissue. There's no special dosing or anything for the antivenom. We just want to try to get the antivenom in as quickly as possible to prevent as much tissue damage as we can. We actually had a case a few years ago where a patient was transported by private vehicle, bypassed many hospitals for 4 hours to get to our facility. And by that time, there was a lot of bleeding, a lot of tissue damage had already been done. I think it'd been like 4 hours after the envenomation. So we want to just get them to the nearest facility.
Jeez, that's a sad story for sure. Okay, they now arrive in the emergency department. What do we do, and what are kind of the key triage questions that we need to ask?
Yeah, so I like to think of these as these are true medical emergencies. Again, time is tissue. I've talked to our triage department and gotten a protocol where it's just like somebody who has had a seizure or is having a STEMI or is hypoxic. These are medical codes that we need to get to a room as quickly as possible. We don't want them waiting in the waiting room for 2 or 3 hours before we can assess them. So we want to get them triaged, get them into the back as soon as possible. And it's, again, the same way we approach all of our patients is airway, breathing, circulation. And then we want to get a history. So what time did the bite happen? How many bites occurred? Some patients are unfortunate, they get bit twice. We had a young patient, the snake was like under the vehicle and unfortunately got him twice just because he wasn't able to move back quickly. Or adults do not smart things and they may try to pick up a snake. And we've had a couple patients who get bit on one hand and then get bit on the other. So things happen. So you want to try to get a history of how many bites, what time it occurred, any treatments that they did, because you're going to have to undo all that if they put their mouth on it and try to suck on it. And then you want to get a history of, what were their symptoms. Some patients will have this metallic taste in their mouth. Some patients may feel numbness or tingling. Thankfully, our snakes up in Northern California don't have potent neurotoxins. Really, the only one here in California is going to be the Mojave green, which is much further south. But they will often have like paresthesias or some sort of like muscle twitching type symptoms. Obviously, pain's going to be a big part of it. You want to get a history of any like coagulopathies. So if they've had heavy nosebleeds, heavy periods, if they're on an anticoagulant, you want to get that sort of history. And then you want to get a history of if they've ever been envenomated before, because it's likely that they received antivenom with that envenomation. And that just increases the risk of anaphylaxis and serum sickness and all that other stuff that some patients can develop after the antivenom.
Okay, so obviously non-venomous snakes can bite people as well. How do you determine if the snake was venomous? And I guess kind of along those lines is like, how do you determine if you need to treat with antivenom and which one?
Yeah, so if you have a picture or if somebody is out there and they know they're snakes. So our snakes we only have, again, one rattlesnake here in Northern California. There are many pit vipers in North America. So there in the south, there's going to be the copperheads and the cottonmouths, the Keystrodon species. But we only have rattlesnakes out here. So if the snake clearly has a rattle, they're going to have triangular heads. They're going to have elliptical pupils. If you get a picture of them, great. That's how we're going to kind of help triage. But if you don't have a snake picture or anything to identify it, what we're looking for is evidence of envenomation. And with our snakes, they're going to be cytotoxic and hemotoxic. So the cytotoxicity is going to look like swelling. So if you get bit on the hand, you're allowed to have a little bit of swelling around the bite site. So anytime you're going to, puncture yourself with, even if you did it with like a nail or something, you're going to have a little bit of localized swelling, pain. But as soon as you start to have swelling away from the bite site, certainly if it crosses a joint, that's evidence of envenomation. We're going to start doing the antivenom as soon as possible. The other side of it is maybe they don't have a lot of tissue swelling at the moment, but maybe they've got some evidence of coagulopathy. And the coagulopathy is going to look like multifactorial. So they're going to have low platelets, and then they're going to have what looks like DIC, but we call it VIC, so venom-induced consumptive coagulopathy. So their fibrinogen is going to go up, their INR is going to go up, their platelets are going to go down, and they can start bleeding. So if there's laboratory evidence of that, or if there's just any evidence of bleeding, like lots of bruising, lots of oozing of blood everywhere, we're just going to start doing antivenom.
So it sounds like we need to draw labs beforehand. CBC, coags. BMP? I mean, do we just do it because we whatever?
Yeah, the BMP is not truly helpful. Maybe it's a baseline, but it's not truly helpful. But definitely a CBC, we want to know what their starting hemoglobin is. We want to know what their platelets are. And then sometimes providers will order what's called the DIC panel, which are going to get fibrinogen, D-dimer, PTINR. We actually don't really need most of that stuff. We really just need the INR, fibrinogen, platelets. If you get a D-dimer, it's going to be really high and we don't really know what to do with it. So it's kind of waste of lab testing. There's some money involved in that you probably don't need to spend. Sometimes we'll get a urinalysis later on just to see if there's any evidence of rhabdo, but that can be later on down the way. For the bites, you want to mark the bite site, and sometimes you may see 1 or 2 puncture wounds. Just mark the bite site, and then what we're going to do, at least with the California Poison Control System, is we like to do what are called circumferential limb measurements. So we're going to draw some lines around the patient's limb. We're going to hopefully do, above and below the bite site, and the lines are going to be where we're going to put the measuring tape every time, and that's so we can get reliable, repeatable, objective data on whether or not there's progression of swelling and that there is venom still present. So again, take one of those flexible measuring tapes that are in the pediatric emergency department. They're usually in every emergency department. Go on both sides of the measuring strip. It's going to look like railroad tracks. And that way, every time the nurses can put the measuring tape in that spot, and we're going to measure the limb circumferences at those spots. You can label them whatever you want, A, B, C, 1, 2, or 3, just so that everybody's doing the same spot every time. Those limb circumference measurements are going to help us to treat the patient with antivenom, and also we'll know when to stop using the antivenom.
And when you say mark the bite, you're talking about the swelling, the edema around the puncture site, like outline that, right?
Well, you don't necessarily have to do that. You can just you can just circle the fang marks.
So you know where it is.
So you know where it is. So it's a little controversial. There's a couple ways to monitor swelling. The California Poison Control System, and it's definitely us over at UC Davis Medical Centers, we do what are the limb circumference, but there are other places that are going to use what's called the leading edge, and they're going to start to mark the leading edge of the swelling. And I just think that that's too complicated, and I don't think that there's good repeatability with that. So at least with the California Poison Control System, we've developed how to manage a bite site that we can actually fax to healthcare facilities that don't have medical toxicology on staff. And it goes through how to mark the limbs and how to measure them. And then they can certainly call us at any time to help with whether or not a patient needs more antivenom or not.
Okay, so we're seeing swelling, you're seeing lab changes. How do you decide when to actually give antivenom, and what are our options out there?
Yeah, so any evidence of coagulopathy, so bleeding, lab abnormalities, or limb swelling that's beyond the bite site, then we're going to start doing antivenom. And there's going to be 2 that are available. And the one that's been around the longest, the brand name is called Crofab. The generic name is Crotalidae Polyvalent Immune Fab and ovine. So Fab is just FAB. This is a sheep-derived. The newer one, the brand name is called Antivip, and the generic name is Crotalidae Immune FAB2, and it's a horse-derived or equine-derived. And so there are some differences in how the antivenoms are made. So the Crotalidae Polyvalent Immune FAB is created by injecting small amounts of venom from 4 different pit vipers in North America. It's the Western diamondback, the Eastern diamondback, the Mojave rattlesnake, and the cottonmouth. The Crotalidae Immune FAB2 antivenom is created by injecting small amounts of venom into a horse from the Bothrops asper and the Crotalus diuresis, which is a Central American rattlesnake. Both are going to be effective for the rattlesnakes we have here in Northern California and throughout North America. If you're in the South or parts of the East Coast where you have copperheads and water moccasins, because of how the venoms are made, you're going to want to use the Crofab because that antivenom is created by injecting the cottonmouth. And so you're going to have a little bit better activity against the Echistrodon species, which are the copperheads and water moccasins. Both of these should be readily available. You may have a healthcare facility that just has one or the other just because it is going to be expensive to have both on hand. At our medical center, we have both, but we deal with several healthcare facilities through the poison control system that just have one.
Do you think that most emergency medicine physicians feel comfortable starting this medicine on their own? Or do you think everybody's mostly calling poison control? Or when do you recommend people get help?
Yeah, at least here in California, where you're going to most likely have been exposed at least one time to a rattlesnake envenomation, I think that most emergency physicians are going to be comfortable starting the antivenom. What may not be comfortable is what do you do if there's not overt evidence of envenomation and that maybe this is a dry bite, right? So how do you feel comfortable not giving antivenom to a patient who has been envenomated? There's a picture of the snake and they know that they got bit, but there's just not very much tissue damage and there's no evidence of coagulopathy. It's always uncomfortable to not do something, some sort of treatment if you have it. And I've actually personally got to take care of a dry bite in our emergency department several years ago. It was an adolescent who got bit on the lower extremity, and I just happened to be working the shift in the pediatric emergency department. And so I got to watch him all night and make several visits to his bedside and see that there was just no progression of swelling. His labs all looked great. And that's going to happen in about 20% of patients who are bit by a rattlesnake, is they're going to have a dry bite, meaning that, yeah, they were bit, but no venom or not enough venom was injected that they're going to have any sort of tissue damage or coagulopathy. And so it may be that if you're not comfortable with that, just getting, calling the poison control system, or, if you have a medical toxicologist on staff, to just shoot it over with them, make sure you're doing the right thing. We're always there to help.
Yeah, I appreciate that you guys are there, as well as the Poison Control Center, right? Correct.
We actually deal with more rattlesnake bites through the California Poison Control System than we do at our own facility. And I think that has to do with, we're more of an urban center, and a lot of these envenomations are occurring in the foothills. The foothill hospitals have some good experience with treating rattlesnake victims because they see it more often.
Any medications we should give before starting antivenom?
So for the antivenoms themselves, it's not recommended that you need to give them any steroids or diphenhydramine or antihistamines. You don't need to have epinephrine, going or starting. You should have them available in your ER before, but it's not necessary to do any pretreatment. The rate of anaphylaxis to the antivenoms are really low, so we don't need to give them any pre-medications, but you can treat pain. So these are going to be painful, and it's probably going to be more than just acetaminophen painful. And we don't want to use any non-steroidal anti-inflammatory medications at this point, just because of the antiplatelet effects that a lot of these NSAIDs will have. And so we want to just, Tylenol, they may need some morphine or hydromorphone. And then the only other thing that they really need is a tetanus if they haven't been up to date. But we're not doing any antibiotics. And then we're just going to start the antivenom. If they've been out hiking and they're sweaty and dehydrated, you might give them some fluids as well. But we don't need to do any sort of pre-treatment for these folks.
Okay, once we start it, what are we watching for? Just speaking about the emergency department aspect of it, obviously they're going to have to be hospitalized someplace else.
Yeah, so any patient that you've decided needs antivenom is going to be admitted to a healthcare facility at least for 24 hours. So what we're going to do in the emergency department is we're going to give them that initial dose, and then we're going to start trying to find them an ICU bed somewhere. But we still need to keep monitoring the bite site. And so what we're going to do is the antivenom is going to go in, and then we're going to keep measuring limb circumferences every 15, 30 minutes for several hours afterwards to see if there's progression of swelling. And what I think is a common error in treating snake bites is that there's an expectation that the swelling is going to go away when they give the antivenom, and that's just not true. The antivenom is there to stop the progression, and then the swelling will go away, in a week or so with lymphatic drainage and whatnot. So what we're looking for is just the progression of swelling is stopped. For adults, we tend to use like a cutoff of about 1 centimeter. So if their limb circumference is increasing by a centimeter, we're going to give them another dose of antivenom. For kids, they don't have as big as limbs. I tend to use like a 0.5 centimeter to see if there's progression of swelling. And then if there's no more progression of swelling, then we're just going to pause. And we're going to just admit them to the ICU. But if they're stuck in your ER for a few hours, you do want to make sure that you're doing those measurements, that you're looking at the wound. Usually we'll do an initial blood panel, and then we're going to repeat that blood panel in about 6 hours just to see if there's any change. So there may be no more evidence of cytotoxicity, but you may have some coagulopathy that you need to treat. And so you're going to do more antivenom based on evidence of coagulopathy or evidence that there is still progression of swelling. But once all those things have stopped, then you can take a step back, and that patient is just going to be in an observation pattern for a while.
How often are you checking the limbs, and what's the dosing spacing for the antivenom?
So the initial doses of antivenom, so if you're going to use the Crofab, you're going to give an initial dose of 4 to 6 vials. I tend to go with just 6 vials because I think if you got envenomated, there's evidence of tissue swelling, coagulopathy, whatever, I just want to get it in and try to do as much damage control as I can initially. There are some providers who will argue, well, let's try to use the least effective dose. And I totally get that because these antivenoms are relatively expensive, and there is an increased risk of serum sickness as the dose goes up. So we want to try to use the lowest effective dose, but I tend to give the first dose just the 6 vials of the FAB, Ovine, Crofab, or if it's the Anavip, which again is the Crotolide Immune FAB2, the equine-derived one, initial dose is going to be 10 vials. So this is one of those things where just because you're giving more vials of one does not necessarily make it better. It's just a different formulation, just how they're packaged. So I tend to give the full dose, so either 6 or 10, and then we're going to do the limb circumferences every 15, 30 minutes for at least 2 or 3 hours. And if I see any evidence that we have not gained what's called control of the bite, so there's progression of swelling, then we can just give another dose of antivenom right there. So there's no real time interval. It's just whenever you gain control of the swelling. And so if it happens that you infuse the first loading dose and it just finishes and 30 minutes later you're noticing that there's still rapid progression, then you're just going to give another dose. And so that second dose changes, and it kind of depends on where you are, but our group tends to, at that point, try to use the lowest effective dose. So for the Crofab, we might just give the 4. If it's the Anavip, we might just give 5, just to try to cut back on the amount that they are going to receive. But we can always give them more, right? So we're just going to dose them every hour or 2 until we get control. Then they are going to go into the observation pattern for 24 hours. Which is done upstairs, and we are again doing the same limb circumferences same blood tests. Once they're in control of the swelling, we can back off the measurements to every 2 hours. It's very nursing intensive if we're doing them every 15, 30 minutes initially, but once we've gained control, we can back off and space it out a bit. And then we're doing the blood tests about every 6 to 8 hours just to see if there's any evidence of the coagulopathy.
What resources does a hospital need to be able to keep that patient? So when do I know that I need to transfer?
Yeah, so these patients really should be in intensive care. There's a lot of nursing care that needs to be done to do these measurements, the blood testing, and then if you're going to give an antivenom, it really should be done in a monitored setting. And so that's why they need to be in the intensive care unit. And that's protocol for our hospital. And I imagine that's protocol for many other hospitals to be in a monitored setting. And again, that's just because that there is a non-zero risk of anaphylaxis, and you want to be able to treat that if you encounter it. And then the other thing I'll add is that do you have enough antivenom? So whenever we get one into our own facility, we'll talk to our pharmacist and be, hey, how many vials of X do we have? So if you're at, maybe one of our rural hospitals and you've only got, a dose or two, you might have to start A, looking for more antivenom, or B, looking for a place that can take over that has more antivenom. And we've seen that a couple times with some of our local hospitals that they just didn't have enough antivenom, and so we'll have to help them find where to get it. So poison control staff can help find more antivenom, and so you want to make sure that you have the capabilities in that sense to treat them.
You mentioned tetanus. Is there any other wound management or other things that we need to be thinking about? Like, should we wash out the wound? Do we need to give antibiotics?
Yeah, just a gentle wash is really all you need. They don't need to be scrubbed. And then we don't do any antibiotics. So again, these are relatively just not dirty wounds. I haven't seen one yet get infected. I haven't heard about it unless somebody did something to make it worse, like put their mouth on it or cut it or do something bad to it. And so we don't do any prophylactic antibiotics. The wounds themselves can be tricky to manage. I think it depends on where they are. So, we get a lot of extremity bites, a lot of hand, foot. And the wounds, typically we don't see them in the emergency department, but upstairs, we're going to see blisters that start to appear. So they can be hemorrhagic. They can just be like clear serous fluid filled blisters. There's a little bit of controversy on what to do with those. I tend to leave those alone and just let the body reabsorb them. There are some places that are going to debride them. And I think that that's an area where we need a little bit more research into what to do with them. I did have a patient that was in quite a bit of pain from a blister several years ago that we decided just to debride that one to help with the pain. But for the most part, we want to keep those blisters intact because it is protecting the skin and protecting against infection. But as far as the wounds themselves, just keep them clean, soap and water. Nothing really needs to be done to them.
What about the compartments, Jonathan? What's our risk of compartment syndrome?
Yeah, great question. Certainly an area of controversy and anxiety with these snakes is there is a lot of swelling. I mean, everybody can look on the interweb and find pictures of rattlesnake envenomations or pit viper envenomations, and they swell a lot. The good news is it tends to be extra compartmental. And that's because a lot of our pit vipers in North America just don't have the fangs to penetrate deeply into the fascial compartment. And so a lot of the swelling is just going to be extra compartmental. And I know that can put pressure on the compartments, but it doesn't lead to direct intracompartmental pressure elevation. And so what we always instruct providers who are managing these snakebite patients is to, if they suspect compartment syndrome, please give more antivenom. And if you still suspect compartment syndrome, please give more antivenom. And then if you still suspect it, please call your most senior orthopedic or hand surgeon to do a true compartmental check. Because the real risk of compartment syndrome is extremely low. And if a patient is taken for a fasciotomy without having true compartment syndrome or being given an adequate dose of antivenom, then their risk of deformity, decreased function in that limb is really high. And so the studies show that adequate doses of antivenom can really prevent compartment syndrome. And again, early doses of antivenom and then adequate doses. Every once in a while these happen, but you want to make sure that it is true compartment syndrome and get good measurements of that compartment before you take a patient off for a huge surgery like this.
Any special considerations for kids that we need to think about?
The good news is, and this may be triggering to those who treat pediatric patients, is that pediatric patients are just like adults in this situation. Yeah. So we get to do the same thing. So the dose is the same. The treatment is the same. The only thing that I will say is different is that, again, going back to the limb circumferences, is that, their limbs are much smaller. So I tend to be much more safer and just use like 0.5 centimeter of increase to know when to give more antivenom. But other than that, it's the same. And that's what makes it great. We don't have to do a weight-based dose of antivenom. And that's because the snake didn't really give a weight-based dose of venom.
Yeah.
We just treat them all the same. And they're really low volumes when they're reconstituted. So we're not going to worry about, volume overload in this child. And we can concentrate them if we need to. But for the most part, we've had some young children envenomated. We haven't run into issue with volume or anything like that. So we just same dose, treat them the same.
What about pregnant people?
Yeah. So I looked this up, and thankfully it doesn't happen very often. I couldn't really find very many studies from North American pit vipers. I found some from around the world, other pit vipers, but the main risk is going to be what's happening to the mother. So if the mother is having bleeding, shock, that's obviously bad for baby. So we want to just treat mom. If mom is doing okay and she's not having any evidence of coagulopathy or cytotoxicity, then baby should be doing just fine. There are a couple case reports of patients who were pregnant, envenomated, and there is a slightly higher risk of a spontaneous abortion, unfortunately, probably due to the stress or the bleeding risk that increases. So it is a special consideration, but we're going to treat them all the same. We can still give the antivenom. It's not contraindicated to give antivenom to pregnant patients. That's really all we have. So we're going to give it to them. And if we treat mother adequately, hopefully we should be able to keep that pregnancy safe and to term.
Yeah, that's scary. What about our elderly population? Anything special or different there?
Oh, that's a challenging population. It's also, gotten more challenging with patients who are on these DOAC, these anticoagulants. So many, even not elderly, but sort of like, middle age are on DOACs for, AFib or prior strokes. And then you have a rattlesnake that envenomates them, and now you put them at risk for more coagulopathy. So for those patients who are on an anticoagulant, we want to know why they're on the anticoagulant. If it's just for AFib, stroke risk reduction, then the good news is we can hold that for a few days while we're managing their envenomation. If it's something like the patient's on warfarin for their mechanical valve, that gets really tricky because we all know that you really just can't stop anticoagulation with a mechanical valve. We've had a couple of those, and thankfully they've done well. What we tend to do in those situations is stop the warfarin, put them on heparin because we can always shut that off. And then we just make sure to aggressively manage their envenomation and diligently check their coags and make sure they're not bleeding or getting worse from the envenomation. And then once the risk of coagulopathy from the envenomation's over, we can put them back on their medications.
Are there any other medication contraindications for antivenom?
Medications, no. There are some relative risk of anaphylaxis with the crofab. So the way that that's manufactured is that there's an enzymatic process with papain. And so if you've got an allergy to pineapple or papaya,
Oh no.
there is maybe an increased risk of allergic reaction to that one. So you want to just kind of be careful on that. But otherwise, there are no drug interactions with these medications. And thankfully, the risk of papaya allergy and pineapple allergy is pretty low.
It's very random.
Yeah.
Okay, I think we have thoroughly covered antivenom. Anything else you think that we should know about snake bites?
So I think, obviously when you're out hiking, just be aware of your surroundings. Make sure you know where you're putting your feet and your hands. Make sure to dress appropriately. So if you're out hiking in your Tevas, it's probably not going to be adequate. You might want to put on some boots. There are some studies that show that snakes can still get through boots, but it's probably a little bit better protection than wearing just sandals. And then, some of our listeners may be practicing in the South or the East, and they're going to have coral snakes. So we only have one, what's called an elapid. So if you break down the snakes into two different groups, You're going to have the pit vipers, and then you're going to have the elapids. And so the elapids, they're harder to differentiate between non-venomous snakes because they're going to have the same head shape and pupil shape and all that stuff. You're going to have to differentiate them by their colors, and hopefully you're not getting that close to even need to worry about that. But in the south and in the east, we have one elapid called the coral snake. And this is a strictly neurotoxic envenomation. And the most potent one is going to be the eastern. So this is the one that's like in the Gulf states, Georgia, Florida, those areas. And if you're envenomated by one of those, you're going to want to do the ABCs, particularly focusing on breathing because it is a neurotoxin. They can develop hypoventilation and need support. The antivenom for coral snakes is a lot more difficult to find. It's not manufactured in as high volume as the crotalid antivenom. So you're going to have to call around. The poison centers are going to be a great resource to know where to find the antivenom. And then you're going to want to give the antivenom, and then those patients get observed because, again, even if they don't have signs of it, they get observed for at least a day just to kind of make sure that there's no delayed neurotoxicity. But thankfully here in North America, we're pretty safe with our snakes. We don't have that potent of neurotoxic snakes. Again, the only elapid that we really have is in the south, the coral snake.
Jeez, that sounds scary. Glad we're not hiking around those here.
Well, that was an amazing amount of information on snake bites. Dr. Ford is a wealth of knowledge in general, but especially when it comes to envenomations. And he'll be back next time to tell us all about scorpion stings and spider bites.
Thank you so much to our department for being there and having the resources to take care of all of these patients. And thank you to OM Productions for being ready for anything. Until next time, stay curious, stay inspired, and stay tuned.
The opinions shared on EM Pulse are those of our hosts and guests. They don't necessarily reflect the views of UC Davis Emergency Medicine, UC Davis Health, or any of their parent organizations.